Hello, and thank you for attending our presentation entitled Getting Paid Part 2, Key Coding Issues in Telemedicine. Today, our presenter is Suzanne Cassimore, a CPC. She is the coding director here at MTBC. Video and audio works best through the web. If your video or audio is not working properly, the recorded presentation will be posted online after the webinar is completed. Please hold any questions until the presentation is completed. Telehealth. Telemedicine refers to the delivery of healthcare services using audio or video devices, typically in a live two-way audiovisual conference between a patient and a provider who are at different locations. There are two basic methods, store and forward, or the interactive real-time audio and visual. The store and forward, or asynchronous technology, is the transmission of medical information the physician or practitioner at the distant site reviews at a later time. It's permitted only in federal telemedicine demonstration programs in Alaska and Hawaii. So to qualify for a telehealth visit, one of the qualifications is that the technology must use an interactive audio and video telecommunication system, interactive, that permits real-time communication between the provider at the distant site and the patient at the originating site. And that gets into what actually qualifies as a telemedicine visit. What is an originating site? The originating site is the location where the patient receives the medical services. So it's where the patient goes to get these services. Now, the originating site must be located in either a county outside a metropolitan statistical area, an MSA, or a rural health professional shortage area, a HPSA. Now, if the originating site is located in one of these areas, the sites can also be a physician's office, a hospital, a rural health clinic, critical access hospitals, federally qualified health centers. So it's typically a patient goes to their physician's office and they need a specialist's opinion or to be in contact with another physician, and that is when they will have these telehealth services, and those would be qualifying originating sites. Now, if you're uncertain whether the originating site is eligible, you can utilize the Medicare's telehealth payment eligibility analyzer, and you go to the website, enter the location of the originating site, and it will let you know whether or not it is an approved originating site for telehealth services. Now, the distant site practitioners, so the practitioners that you are going to have the telemedicine service with, they can be physicians, nurse practitioners, physician assistants, nurse midwives, clinical nurse specialists, registered dietitians, and nutrition professionals. So any type of those providers can be the distant site practitioners that are providing the telehealth services. And we discussed in the last slide about the communication system requirements. So you must use an interactive audio and video telecommunication system, and it has to permit real-time communication between the practitioner at the distant site and the patient at the originating site. So they must be able to communicate back and forth. Again, the asynchronous store and forward technology is only permitted in the federal telemedicine demonstration programs in Alaska and Hawaii. And finally, what qualifies as a telemedicine visit is what codes, what services are permitted for telehealth. There is a list of codes that are sent out each year by Medicare, publishes them on a yearly basis, and information on which codes are permitted, common, and utilized as telemedicine codes. So here are some of the more common services that are provided: office and outpatient services. There are inpatient consultations, consultations in skilled nursing facilities, psychiatric and psychotherapy services, and there's many more. And for a complete list of all the codes that are permissible, there's the website there where you can go and download the codes that are permitted for 2019 services. In addition to coding for the services, Medicare has also created it's a facility fee, if you will, reimbursements, code Q3014. And Medicare has designated it as a telehealth originating site facility fee. So the originating site can bill this code to Part B and get reimbursed for utilizing their equipment for providing these telehealth services. And there are other codes that, aside from, the telehealth list, that are telemedicine codes that I thought other codes. One is a virtual check-in that Medicare reimburses for. It's G2012. And this code, as you see, is 5 to 10 minutes of medical discussion. And it gives a bit more of a description of what it's. It cannot originate from a prior E&M or lead to an E&M service within the next 24 hours. There's also a code G2010, which is a remote evaluation of recorded video or images submitted by an established patient. Again, it cannot originate from a related E&M provided within the past 7 days or lead to, the next available or the visit within 24 hours. So those two codes are available. There are also, believe it or not, telephone, internet, electronic health record assessment codes that Medicare is reimbursing. There are reimbursements for these codes. 99451 through 99452 is when the patient, and it has the different times, 5 minutes or 30 minutes, and code 99446 and 99449. So these codes do have reimbursements for Medicare. So look into utilizing these codes as well for additional reimbursements utilizing your telehealth services. Now, these are the codes, but what documentation is required, which is typically, one of the first questions that people ask. What do we have to document? Requirements for any of these telehealth services is you would document as if you were seeing any patient office visit, the same fashion as if the patient were physically present in the office at the location. You would choose the levels of E&M visits based on the same criteria as if the patient were physically present at your location. So again, that's if you were providing a new patient telehealth service 99201 through 99205. So you would determine whether you were billing a 99203 or a 99204 based on, the documentation of history and medical decision making. And the physical exam piece is quite difficult when it comes to telehealth services, especially when it comes to new patient visits. There is a time factor that can be utilized when more than 50% of the visit is being utilized for counseling, coordination of care, and as long as that is properly documented and the time factor can be utilized in lieu of having a full physical exam, so you can still get those higher level E&M visits, if you're basing it on time. Location, you must document, a statement that you're providing the telemedicine services and the details of the equipment that was used. So if you were using a cell phone or a computer, what the equipment was. The location of the patient. So where is the patient at the time? And obviously the location of the provider. So where are you, at the time of this visit? And the name of all the persons participating within this call and their role in the encounter should be documented. So those are the additional documentation requirements, at least that should be listed, like I said, in addition to how you would document the visit as if the patient were physically located at your office. So now we've documented. Now we have telemedicine services. It's a bit different in so much as for Medicare. Medicare has created a place of service code for telemedicine services, which is 02. Again, if the patient is in the Federal Telemedicine Demonstration Project in Alaska or Hawaii, they would have to utilize a modifier GQ. So there is a modifier GQ that is utilized for that. Medicare used to require modifier GT on all of its services, but they're phasing that out. As long as you utilize the place of service 2 for telemedicine, that should be sufficient. Medicare will pay your services based on the provider fee schedule. And there is also a modifier that Medicare is utilizing for acute symptoms of patients with an acute stroke. So they will also pay for that with modifier GO is valid for that. Now, there is also a modifier 95, which we'll talk about a bit in our next slide, which is regarding our private payers or commercial carriers. Up to this point, we've been talking about Medicare and Medicare guidelines and Medicare rules and documentation. Now, when we get to the private payers, as always, private payers are always a bit different as how to code for them and what the rules are. The good thing about telehealth and the private payers, the commercial carriers such as Blue Cross, Aetna, Cigna, and United Healthcare, they all cover telemedicine. There have been parity laws, which are requiring that states requiring private payers to reimburse the same amount for telemedicine services as would be comparable for the in-person service. So 36 states have enacted telemedicine parity laws. So they're all reimbursing. The only difference is that each payer, each commercial carrier is determining its own coding rules and guidelines. So you would need to contact each payer or for policies to determine how they want their telemedicine coded and how they want it transmitted. Some carriers are utilizing the place of service to, and some are not. Some are requiring that modifier 95 be used, which is indicating that it is a telemedicine service. Again, the good thing is that all the major carriers are covering telemedicine, but reimbursement is policy driven. I know we've talked about this in another webinar, but it means that one patient might be covered under the policy's benefits and another may not. So it really depends on the patient's specific policy that they're covered under to determine what, if any, telemedicine services are reimbursed under their policy. And again, the rules and regulations or guidelines of how they want, telemedicine to be coded and submitted to the carriers. So my suggestion would be for all the commercial carriers to get the front and find out what their coding policies are. And here's an example of some of the questions that should be asked. This can be done as a general. Call United Healthcare and ask these questions as a general, and then each patient's benefits should be checked to see if they even have telemedicine benefits based on their policies. So you want to ask which codes are covered. Are there any patient location restrictions? So originating site restrictions, documentation requirements, frequency limitations, modifiers needed. These types of questions would, benefit your office practice to know exactly how these carriers want to reimburse or will reimburse. And again, checking each patient's benefits prior to going ahead and getting these telehealth services on board for certain patients that may or may not have the reimbursement for them. Now, that's basically the coding, for currently for the around the corner. There are some good things coming down the pike, always lots of changes. The AMA, they've created 6 new digital evaluation services or e-visits. In which the providers can connect with the patients at home to exchange information. And those codes are 99421 through 99423. And there's also 98970 through 98972, which focuses on communications with non-physician healthcare professionals. So they have a set for providers or physicians, and then they have a set for non-physician healthcare professionals. And those should be coming out in January 1st. So that is a great thing to look forward to. They're also adding some codes for opioid abuse treatment. There's 3 codes that are going to be added. These are G codes. So these are it's for office-based treatment for opioid use disorders, including development of treatment plans, care coordination, individual therapy and group therapy, and counseling. It's per calendar month, so there will be more information coming out about those. So if that is within your specialty, please keep an eye out for those codes. Again, they should be hitting around January 1, so you should start seeing some information about about those coming out. And finally, they're adding the benefits to the Medicare Advantage plans. It used to be where, they were just sort of having the options to have telehealth, but now Medicare is investing for these Medicare Advantage plans for the telehealth programs. So they will be offered for all Medicare Advantage plans, these telehealth benefits, same as if it was a federal Medicare plan. So those are some exciting things that are coming in 2020 for telemedicine. And finally, just some things to think about. Remember, as you're ready, ramping up for telehealth. Telemedicine is a $38.3 billion global market, and it's projected to more than triple by 2025. So now's the time to get on board. There is a lot of information, and there is, a lot of setting up and making sure that, you're using the right equipment, following the CMS guidelines, checking with your commercial carriers to make sure that you're following their guidelines and their documentation guidelines. Again, most of this information comes out on a yearly basis, but it's a technology that is advancing so quickly and is catching on that, on a quarterly basis, they're coming out with new codes and new information. It's good to keep online with that, keep up to date. And you also want to make sure that you check your benefits for each one of your patients, for your commercial carriers, to really get that information solid with the patients, with setting up tele services for them. I thank you, and I hope you found the webinar informational. And if you need some more information, please go to www.talkmd.com for additional information. Thank you again. If you have any questions, we will return those questions to you within a 24-hour period. Thank you, and have a great day.